So, hello, my friends. I'm Dr. Srgio Rowinski from São Paulo, Brazil, here from Show the Planet. And today I have the opportunity to talk about something that I love to talk about, which is greater tuberosity fractures. I'm going to try to summarize in just 20 few minutes what I think is most important in this very important issue, which is greater tuberosity fractures, and I'm gonna talk about this from acute scenarios to chronic and difficult scenarios. So firstly, how can a greater tuberosity fracture present in our daily clinical practice? Well, in two different situations. Here we are seeing the greater tuberosity fragment, which can be small or even bigger, depend on every case. But they can happen in our clinical practice in two different scenarios. Firstly, of course, they can happen isolatedly as an isolated fracture, which is quite common, and eventually in a two-part anterior fracture dislocation. So they can be isolated or maybe associated with an anterior shoulder dislocation, and which is called a two-part anterior fracture dislocation, which in the acute setting must be, of course, reduced. And how can we fix a greater tuberosity fracture once, of course, there is indication of fixation? Well, we can use many things. We can use screws, we can use key wires, we can use TBWs, tension band, wiring, plating. All of those possibilities, they are fully described in literature. So here we are seeing some examples, a screw with a washer, even with some key wires, an AO drawing of a screw with a cannulated screw, here a tension band wire, another drawing from EO books, and even plates once someone finds it necessary. But the thing is that in all my practice, in 17 years of dedicated exclusive shoulder and elbow surgery, doing a lot of shoulder and elbow trauma, I have been witnessing a lot of trouble, and I have seen and I have already had many trouble with all of these devices in my life. So here are some examples. Here we are seeing a greater tuberosity fracture fixed with two screws and complete loss of reduction and complete failure of the surgery. This is another example, a left shoulder with complete loss of surgery, total loosening of the fixation after fixation of a greater tuberosity fracture. And I have witnessed it, and I have seen countless times these scenarios in my life. Here another complex scenario in which someone has done a phyllos plate in a proximal humerus fracture, and again total loosening of the greater tuberosity fixation, as we have seen here, which is a very, very difficult issue to fix. So the thing is, how have I, Dr. Srgio Rowinski from Show the Planet, found peace in fixing these problems? Well, the thing is, the best answers that I could find in my life, they are in this book, which is a very important book in our specialty, which is Complex and Revision Problems in Shoulder Surgery. And the answer is so simple and so important that it's designed literally in the cover, which is Trans-Osseous Sutures. So I and many friends of mine here in Brazil could only find peace once we understood that the answer, to the best of our understanding, in greater tuberosity fractures relies on Trans-Osseous Sutures, and I use nothing but that, and that has been a complete game changer in my life from 10 years to now. There are many ways of doing Transosseous suture. I have studied this in many books, in many articles, and I have a personal way of doing this, in which I'm coming to that in a second. You can do a lot of sutures passing through the borders of the fragments, as we are seeing here, which personally I do not recommend. You can do something like a figure of 8, a transosseous figure of 8, which is something that honestly I don't do. I think that we can do things in a simpler way, But there's a very important message in this picture and in this other one, in which someone is doing Trans-Osseous suture in figure of 8, which is you have to pass your suture. It can be with Ethibond number 5, with fiber wire, it doesn't matter, not through the fragment itself, but through the posterior superior cuff, the supraspinatus and the infraspinatus, as we are seeing here. The sutures shall not pass through the bony piece itself, because the bony piece itself is very fragile, very weak, even in big pieces, bigger fractures in younger patients. I have a lot of experience in this, as many of the panelists here. So the message is you must pass the sutures, the osteosutures, through the posterior superior cuff and passing out, as we are seeing inferiorly here in the metaphyseal part of the proximal humerus. So this is what I do. Depends, of course, on the morphology of each case, but I do one suture. I only use number 5 Ethibond sutures, one from posterior to anterior, passing anteriorly on the metaphyseal part of the proximal humerus, and a second one passing posteriorly. And 2 sutures, to the best of my understanding, is absolutely enough. So this is how I like to do this, leading hands to a construction like this. Sometimes, depending on the morphology of the fracture, I like to pass an horizontal suture, like we are seeing here in yellow, but it depends on the case. So there is a message in this lovely book, which is Complex and Revision Problems in Shoulder Surgery, and this again has been a game changer in my life, which is this idea. So what is this idea saying? The idea is exactly this: in greater tuberosity fractures, even if you use devices like screws, implants, cannulated screws, key wires, anchors, always add transosseous sutures to your construction. But I go beyond, and I say, and I quote, you need nothing but transosseous sutures. This is the best way I can understand this, and this has been, for the 3rd time in this lecture, a game changer in my life. So what about the surgical approaches to fix a greater tuberosity fracture? There are 2 possible approaches, of course: the deltopac, which is definitely not the best one, and the anterolateral approach with the deltoid split, which is done in the upper part of the anterolateral approach. This is a message for the juniors. The deltopac approach is a very boring approach, or at least not the best approach to deal with greater tuberosity fractures. It's kaffee-mechanati, it gives you a lot of difficulty, trouble, while the deltoid split is fantastic, tears of joy, and it's our working horse, as we all know. Anyway, when should us use a deltopac approach to treat a greater tuberosity fresh fracture? So there is a situation in which I see, which is not exactly chronic, but subacute 2-part anterior fracture dislocations. I don't want to change the subject, because chronic anterior shoulder dislocations or chronic anterior fracture dislocations of the shoulder, they are very difficult to manage. This is another issue, and they need bony block procedures like the head and Hibinetti, like a Latarjet. But when you have subacute 2-part anterior fracture dislocations that come to you 1 week after trauma, 2 weeks, max 3 weeks, they are relatively fresh, but they are not reducing under anesthesia. What you can do is reduce it with a deltopac and fix the greater tuberosity, and I only do that with transosseous sutures. I have a relatively big experience in these specific cases, and this is a very pedagogical example. So this is my first case, a 38-year-old woman, which was convulsive. She was having problems to treat with the neurologist in the public system here in Brazil. She had a convulsion in 14 September 2017, and she developed hence a 2-part anterior fracture dislocation. And for many social problems that are beyond my control, she only came to us in my public hospital, where I do all of my shoulder and elbow trauma 2 weeks after with a 2 weeks old lesion, and we ended operating her 3 weeks after the trauma. So that was the scenario. A 3 weeks old 2-part anterior fracture dislocation. It was not reducing. So we took her to surgical center. We did a delta pack. This is the immediate C-arm view in the beginning of the surgery. It was not difficult to reduce the shoulder. This is a delta pack. Obviously, you have to do a biceps tenotomy and then to do a biceps tenodesis in the end of the surgery, wherever you want. But here we can see a very, very pedagogical and beautiful osteosuture of the greater tuberosity done with 2 number 5 Eti-bond sutures. So it's very cheap, it's very easy, and it's definitely the best way I think we can do that. This is the final video. As we can see, absolutely anatomical reduction. The long head of the biceps is with a whip stitch inferiorly and a very good fixation. Since it was a delta pack approach, it was very easy for us to see here the cephalic vein. The immediate post-op view in the very end of the surgery, as we are seeing here on the left side, and this is 1 week post-op view, and this patient had a very, very good final clinical and hagiographical evolution. But we have to understand that the vast majority of greater tuberosity fractures shall be and can be operated by a deltoid split. So the deltoid split is very common for all of us. It's the upper part of the anterolateral approach. Generally, as a rule, you don't have to see, to identify, and to isolate the axillary nerve. But in chronic cases, as I'm going to show you, sometimes you have to do it, and I'm going to show you in a minute. So the deltoid split is a wonderful approach not only to deal with greater tuberosity fractures, but also to deal with the posterior superior rotator cuff in a way that it's a wonderful approach to do open rotator cuff repair. Obviously, shoulder surgeons all around the world are doing this arthroscopically nowadays, but this is a wonderful approach for open rotator cuff repair too. And this is another view of an extended deltoid split in a very old case that I did many years ago, in which here we see the greater tuberosity, and there is a message in this photo, which is: you shall never manipulate the greater tuberosity fragment with instruments because it's a very fragile bone. So you always manipulate greater tuberosity fracture with whip stitches, as we are seeing here, as horse reins passing through the posterior superior cuff, the supra and the infra, as we are beautifully seeing here in this picture. So this is a very typical case, a 64-year-old woman. She was quite tiny, but she loved to swim. She was a swimmer. She had a fracture. That was 5 years ago, 7 February 2017. I operated her because of a lot of difficulties these patients they have to come to my hospital basically 40 days after that, which was 16 March. So she had a very typical greater tuberosity fracture, and it's very important, my friends, for all of us always to have very well positioned x-rays. So here we are seeing a true AP view in which we don't have is almost true, because in a true AP view of the shoulder X-ray you don't have sobreposition of the humeral head over glenoid. It's an external rotation. We have a clear view of the subacromial space. So it's very important to be very harsh to get proper images, proper X-ray images. So here we are seeing a greater tuberosity fracture with more than 5 millimeters of displacement. She loved to swim, so I didn't want to give a chance, and I indicated surgery. This is the right side, the affected side, and this is the unaffected side. And it's very important for us always to be very harsh to obtain proper images, as we are seeing in this case. And here we are seeing the greater tuberosity fracture. This is the lat view, a perfectly positioned lat view in which we are seeing here the affected side, the other side, and an evident superior migration of the fragment. This is a spot, a zoom view of the lat view, perfectly positioned, the right side, the unaffected side. So here we can see the superior migration of the fragment, and is very important for us in the hand, in the knee, in the foot, in the shoulder, it doesn't matter, never to accept badly positioned x-rays. So this is the C-arm view, a very nice view in which we can see in the beginning of the surgery the fragment. Here we are seeing a video in which I did an osteosuture. It's very important for us to understand that greater tuberosity fractures behave like posterior superior rotator cuff tears. This is not an opinion, this is a fact, this is a concept, and I'm gonna say it again to the juniors. Greater tuberosity fractures, once they are operated, they behave like posterior superior rotator cuff tears, and you must manage them the same. And this is what I'm doing here with greater tuberosity fracture, and there is a biceps tenodesis included in the construction because the biceps was really very ugly in this case. So this is the beginning of the surgery, the C-arm, and this is the end of the surgery. Absolutely anatomical reduction, osteosutures, very cheap, super trustable, and no implants to fail. So this is 1 week post-op. It's difficult to do a nice X-ray with these patients in the very early days of surgery because they have a lot of pain disease in internal rotation. But if we see here 5 weeks post-op, true AP view of the shoulder in external rotation, absolutely anatomical reduction, and here with 4 months, absolutely anatomical reduction. This is a spot of the 4 months post-op AP view in which we can see here the holes that I did to do the osteosutures. So very important message, you don't pass in the upper part the sutures through the fragment, but through the insertion of the posterior superior rotator cuff, and inferiorly with very healthy bony bites in the proximal metaphyseal lateral area. Okay, so this is the lat view pre-op, and this is the lat view post-op with an absolutely anatomical reduction and anatomical takedown of the fragment. And this is the lady, 7 months post-op. She was happy, a very good external rotation, similar internal rotation, very good elevation, and she was hence very happy with her results. And this is what I've been doing for 10 years. But this is the last part of my presentation, which is how can things get complicated? What about chronic cases? So this is very important for the juniors. So chronic greater tuberosity fractures, they may lead to subacromial impingement. Many times they do. They lead to a lot of pain. It's a difficult scenario. We have shortening of the posterior superior cuff, as in chronic rotator cuff tears, posterior superior rotator cuff tears. And some cases can be brought once we operate them to the anatomical side, but some cannot, as some chronic rotator cuff tears cannot be fixed anatomically in the same way. So the diagnosis depends on a very good medical history and physical examination, of course, but we need accurate X-rays. We need them all of the times, in the foot, in the hand, in acute scenarios, but when things get complicated, you must be very harsh on good imaging. So we need a true AP view, which means an X-ray in which you don't see sobreposition of the humeral head over glenoid in external and internal rotation. A lat view, the axillary view may help too, and a CT, of course, if you are in doubt, and or for us to better prepare our surgery. And the treatment, sometimes you can do arthroscopic management. I have 2 cases in my life. I'm not going to show it because of lack of time. Obviously, you try to reduce them when possible, but, and this is very important, when an anatomical reduction is not possible, what I strongly suggest is to remove the bony piece and fix the posterior superior cuff as a rotator cuff tear, many times with medialization of the footprint, which is something I love to do in chronic rotator cuff tears arthroscopically. So this is a very important idea for the juniors to understand. A chronic retracted greater tuberosity fracture with a shortened posterior superior cuff, you must understand it as a posterior superior rotator cuff tear. This is not an idea, this is a concept and a principle. And this is how we manage big tears in open rotator cuff surgery when needed. This is a very old photo. So this is my last case, 48-year-old man who had a greater tuberosity fracture somewhere far away from my hospital here in Brazil in May 2016. He was very, in my opinion, incorrectly, I repeat, incorrectly operated somewhere one month after that, in June 2016, somewhere in Brazil, and he was sent to me in agony and much pain, basically 1 year after, 10 to 11 months after surgery. This was his AP view, the X-ray, 1 year after surgery. So it was very difficult for me to understand what was done with that greater tuberosity fracture. No anchors, no screws, no implants, no signs of transosseous sutures. The scar was in a very strange position, quite weird, which made me conclude that the surgeon that was operating this man honestly didn't know exactly what he was dealing with. And again, it's very important for us to have perfectly positioned X-rays. So this is a true AP view in which we are seeing here no sobreposition of the humeral head over glenoid. This is in external rotation, a very good view of the subacromial space, and we can see here a clear greater tuberosity non-union, and this is in internal rotation. So external rotation and internal rotation are very important views in a true AP view, of course. So this is the comparative view of both sides, the non-affected side, the left side and the right side, and here we are seeing the non-union of the greater tuberosity. I'm pretty sure that basically nothing was done in the previous surgery 1 year before. This is the true AP view in internal rotation, in which we can see what was clear to be, to me, a greater tuberosity non-union with a very, very painful clinical scenario. And this is the lat view in which we can see here in a perfectly lat view the greater tuberosity malunion, and we see here both sides. It was very clear to me what was happening concerning the clinical scenario, the physical examination, the x-ray, so I didn't find necessary to ask for a CT. And so he was in agony, a lot of symptoms, very typical subacromial symptoms, pain to elevate, pain to sleep, anterolateral pain. This man was in agony, and my idea was to try to do something like an osteotomy, something like that, of that small piece, and then after I released all of the fibrotic bony adhesions, then I would manage that as a greater tuberosity fracture. But I was sure that the posterior superior cuff would be absolutely retracted and shortened, and I was completely correct. So I am entering here intraoperatively, doing something like an osteotomy, something like to release all of these bony fibrotic adhesions. And then I go guided by C-arm, so clinically and C-arm guided, and I go very delicately, because when I come to this part, as we've seen on the right side, I cannot damage the cartilage of the humeral head, and I cannot damage the cuff. So all of these movements, they must be very well controlled. And when I come to this part, I stop, because I don't want to damage the posterior superior cuff. So very delicately, I pass 2 whip stitches at this moment of the surgery through the posterior superior cuff, and then I have the fragment in my hands as we are seeing here, and that was a difficult surgery. So here we see the greater tuberosity, something like an osteotomy, because it ended being like that, because it was a malunion. The axillary nerve here inferiorly, and the previous incision, which was quite strange. I'm going to show that in a minute. So as I was expecting, the posterior superior cuff was quite retracted and shortened. I tried to do a lot of releases, as we do in chronic rotator cuff tears arthroscopically. I have experience with that, as all of us have too, and I could release it a few millimeters, but as I was expecting, in the end of the surgery, I threw away the greater tuberosity piece, and I fixed the posterior superior cuff with footprint medialization, which is something I love to do arthroscopically whenever needed in chronic and retracted big rotator cuff tears. So this is 1 week post-op. Here we are seeing the medialized footprints with 2 anchors. Here, my anterolateral approach, which was a very extended deltoid split because there was a lot of fibrotic tissue over there. Here we are seeing 5 week post-op the previous incision, which was quite strange. I'm going to show that in a minute. This is 5 weeks, and this is the patient 5 months post-op. I am showing here this patient has a tendency to develop keloids, as we are seeing. This is my incision, as we are seeing here on the left side, and its relations with the anterosupralateral corner of the acromion, and here the front view. So let's check it out. This is the front view of the shoulders 5 months post-op. So this was my new approach, an extended deltoid split and anterolateral approach. That here we are seeing the coracoid, and being it's the coracoid in blue, I have make a drawing of what would be a deltopec. So in the end, the first surgeon, to the best of my understanding, didn't know exactly what he was doing at all, because it was not a deltopec, not an anterolateral approach. It's to the best of my understanding, a non-existing approach, and a completely bad surgery that was done 1 year before. So this is the patient 5 months post-op. He was much better. He was with a lot of pain when he came to me 6 months before of that. Now we are seeing a very good external rotation. The internal rotation was absolutely normal, and he was elevating both shoulders. Now again, I'm gonna ask him now in Portuguese, do you have pain? And he's saying, no, I don't have pain. So a good result in a difficult case. So this is my take-home messages. The Trans-Osseous Sutures is a wonderful and very cheap, bahut cheap method of fixing greater tuberosity fractures, and to the best of my understanding, they are absolutely enough. I strongly suggest all of you to use it routinely, and if you use something else, any kind of implant, please do it together with osteosutures. The take-home message number 2. The anterolateral approach is the best approach to deal with greater tuberosity fractures with the deltoid split, and you don't have to be afraid of the axillary nerve in more difficult cases. Isolate it, don't hurt the nerve, and be happy if you have to extend the approach. This is a very important take-home message of this presentation. And this is the last one. Greater tuberosity fractures, when they are chronic, they behave like chronic posterior superior rotator cuff tears. This is a very important message. So apply rotator cuff concepts and ideas to your case once you are dealing with chronic greater tuberosity fractures, because that will definitely help you a lot. So Thank you, Dr. Vasudeo Gadegone Mirebahust Doste Friend, for the invitation. Dhanyavad, sir. It's a pleasure to see Show the Planet, my personal project of international education of shoulder and elbow medicine and surgery, invited to this lovely event. I strongly suggest to all of the juniors to subscribe to my YouTube channel, in which I have more than 54 shoulder and elbow videos, quite pedagogical ones, and I'm gonna keep here my WhatsApp, 5 seconds if someone wants to send me a message. I'm not present in this event today, it's very early in Brazil, but once someone sends me a message, I'm gonna reply for sure. Dhanyavad.